Please welcome to the stage Inovalon founder and CEO, Dr. Keith Dunleavy.
Welcome to Customer Congress 2023. Did you all have a good time last night? Yes. How late were you out? All right, we got some great answers. Well, the later you might have been out, that much more appreciation to you being here early this morning. We have an amazing set of activities over the next couple of days, amazing people, speakers, and products you're going to hear about. But most importantly, Customer Congress 2023 gives us a chance to spend time with all of you. Our partners, our customers, the people we work with are the reason we get up each morning. It's the reason why we innovate tirelessly over the years. But 2023 is not just another great opportunity for us to come together for Customer Congress. 2023 is also the 25th anniversary of Inovalon's origins. Being as that is, being that as it is, there were a number of folks that were saying, hey, could you recount these 25 years? Walk us through what were the origins of how we got to where we are. What was the technology? What was the healthcare environment? Give us the timeline. Well, fortunately, Inovalon, of course, has a time-traveling DeLorean in its tech arbitration. And I asked Rajesh to pull one out front up into the Capitol this morning, and we could all hop in and take a little flashback to see and talk and think about these great 25 years. To do that, we need to go all the way back to 1984. I was 15 years old, and I had gotten bitten by the computer bug. While others might have been out playing baseball or basketball, events that I barely understand, I was out cutting hay fields or mucking stalls to get the money to build my first computer, the Heathkit Zenith 64K. I was completely heads in to this thing called programming. And from there, you have to flash forward to my college years. I decided to go to Dartmouth. Why Dartmouth? Their former president, President Kennedy, had invented this thing called the language of BASIC. BASIC was the first language in software programming that started a divergence in the marketplace away from batch processing to more interactive programming. Kennedy had led the university to now have internet in every single room. Every dorm room, in fact, had as many connections as the number of people that were supposed to be in that room. And by the time I matriculated, they required every student to have a computer. As a result of this, it became a battleground between IBM and Apple, both vying for the hearts and minds of the future computer science student. So with only 4,000 students on campus, there were more than 8,000 computers. It was definitely the place for me. But as I arrived, my life was going through change, and my parents were able to support financially me during the first term of school, but unfortunately not after that. I had to take every job I possibly could because I didn't arrive with any financial aid package, but suddenly had to pay for everything as basic as books and food to, of course, the larger problems of tuition. I programmed morning, noon, and night, every job I could possibly find. And it brought me to this place, Kiewit Computational Center. Kiewit was an amazing advanced stage computer facility up in New England that was serving the military's North Atlantic Fleet. It had some of the most advanced programmers in the nation. It was a subterranean computer facility that was perfect for the young mind to delve into computer science. The team there very kindly took me on and taught me object-oriented programming and network programming. One of my most memorable programs at the time that, believe it or not, that's a photo of me from 1980-something, was this program called Questor, which allowed operators that were not technical folk to program in customized questions of different formats and content, and then send out these data requests into the internet to be executed on by ordinary people using ordinary computers, and send the information back and have it be analyzed and reported in real time. For those of you who are familiar with our software today, this was the great-great-grandfather of what is today EPAS. From there, I knew that Dartmouth wouldn't allow me to graduate just with computer science and engineering. It's a liberal arts school, so I had to take other courses, somewhat begrudgingly, I must admit. And that brought me across this man's work, Dr. William Kolff. Dr. Kolff was the father of the artificial kidney. He was also the father of the artificial heart. And I came across a quote of his that struck me. It said, "Someday it should be perfectly possible to pick up the signals from the human motor cortex, translate them to the nerves of the body, and allow the man with a broken neck to walk." This had a very personal impact on me. At the age of 6, I had lost use of my hands and arms due to a burn injury in Philadelphia. I had been starting to already work with social workers and physical therapists because they had to teach me how to feed and clothe myself without the use of my arms. Fortunately, their prognosis was incorrect, and about a year later, I started regaining movement and ultimately had a full recovery, but that left a significant impact on my thinking. And this man's quote said, I needed to start using my engineering capabilities, my computer science capabilities, to not just be for vagaries in the marketplace, but for things that would impact biology and physiology and healthcare. Which brought me to this man. Still having to pay my way through college, I was introduced to Dr. Michael Gazzaniga, who was struggling to write software to read, interpret, and analyze brainwave signals, most specifically the P300 brainwave recognition cycle. So I joined his team and wrote the software that would in fact do detections of early brainwave signal theory at the time, which brought me across this man, Dr. Masaru Ito, who was in charge of the neurology department in Tokyo, Japan. And Dr. Ito had come up with this concept called the microzone theory, now called the Masaru Ito microzone theory. This theory said that the human cortex was actually this recurrent theme of the same cells in a known matrix over and over again. These cells were organized around a cell called the Purkinje cell, and the connections were inherently known. Some were ones that would expand the activity of the cell, others would decrease the activity of the cell. And I said, this is a fantastic application for object-oriented programming. So I started to develop the concept of an honors thesis that would take computers that I had designed for the detection of human nervous signals to combine with object-oriented modeling of the human cerebellum to create early stages of concepts of bionics and implantable motor control. Together with Dr. Samuel Velez, I became convinced that I needed to go to medical school. Dr. Velez said it would just be a shame for the engineer that designs the stuff to not be the one that's there in the operating room to implant it. Remember, these were the days of Steve Austin and the $6 Million Man, and the concept of being able to bring motor control back to those who had lost it was enthralling. So this became the cornerstone of my applications to med school, and voila, I ended up at Harvard. There, I gained this incredible new knowledge of the clinical encounter and clinical experience. I was assigned to a VA hospital and could spend days there talking to the patients. It was a truly incredible time. From there, I still had the challenge of paying for everything, which is pretty tough when it's room, board, and what now translates into well over $100,000 a year. And unfortunately, I didn't qualify for very much support, so it was a constant focus of how next day's bill was going to be paid. The company at the time was Merck Pharmaceuticals that had for 5 years in a row been identified as the most admired company in the world, according to Fortune magazine. I had learned that they had Cray supercomputers in their molecular analysis department of research in Rahway, New Jersey. Actually, the Crays were located in White House, but the actual work was done in Rahway. I applied there for a job, and Dr. Simon Kearsley brought me on as an employee. He said, Keith, we have this challenge. Merck has the largest organic molecule libraries in the world. We've been doing NMR spectrometry on the molecules, and we know which ones in a small sample set affect receptor activity physiologically, but there's so much more data we have to pour through. He said, we're going to start using this thing called a neural net, and we're going to start developing a concept called artificial intelligence. And I was set up on a computer in Rahway to learn early AI programming in 1992. At first, I was given 1 hour a day on the Cray supercomputer. Of course, it came at around 3 a.m. in the morning each night, as I was pretty low on the totem pole, and I would stick around then to make sure the code uploaded properly and ran. Usually leaving around 5:30 in the morning, run home, take a shower. I had a small basement apartment that I paid $200 a month for. My kitchen was a microwave on top of a washer and dryer where I would just microwave water, throw in spaghetti, whether it was breakfast or dinner, and head out again. So a lot of my background is not only computer science, but the understanding of the drive and motivation necessary to succeed was a very important kernel of these early days. I was very fortunate to meet my wife in medical school and ultimately went from Harvard to Johns Hopkins together. We couples matched at Hopkins. We went there because the internal medicine residency program at Hopkins was considered the hardest in the country. My wife and I had decided we would do one more hard thing and then get off the train, was our quote. Well, I didn't do so good of getting off the train, but we went there because the intensity of the training program, because Hopkins had not yet accepted what's called the Libby-Zion case rulings on the number of hours house staff is allowed to work. And so a typical work week there in Baltimore was well over 100 hours a week. The thought was to be able to see a patient's course from admission into the ER all the way through to the point of being stable was an incredible learning experience for the resident, and it was, but it was pretty intense. And to my shock and dismay, after all these years of computer science development, where I was doing AI development for pharmaceutical companies on Cray supercomputers, I arrived at what I thought was one of the most amazing clinical facilities in the world, to learn that they weren't using computers in healthcare. They were using computers to store data. They were using computers to retrieve data. There wasn't any analysis. There was no decision support. There was nobody trying to figure out the right medication to put on a patient. There was nobody trying to figure out a care paradigm that might be better. That was really dismaying to me, shocking to me. Had I made a mistake? To go into so much of my work, to bring it to the clinical environment, to only find that, in fact, on the wards, it wasn't being used. Well, there's my wife and me here in this picture. You'll notice there's a small child in my arms. That was our first child. Why is the child in this picture? Because we really couldn't afford daycare. So we would literally bring the baby to the orthopedic floor and leave her there. And then we would bring her to the cardiology floor and leave her there. And this was back in the day of pagers. When one of us would go on, the other one would go off. We could never be on at the same time because who would take care of the baby? So we literally didn't see each other for the longest period of time, and I'd have to text her. Well, actually, we didn't call it text, but I have to call the page operator, who thought it was really funny that Dr. K. Dunleavy was telling Dr. K. Dunleavy that the baby was on Osler 8 or something like that. And then, we'd go pick up the baby and swap, and, one would drive home and the other would start work. Incidentally, for those historians in the room, there's Dr. Paige Killian. An amazing clinician, amazing person, our chief medical officer at Inovalon today. He's been with us since. And right next to her, Dr. Rochelle Lewinsky, the just recent head of the CDC and good friends of ours. It was an amazing time. But unfortunately, computers really weren't being used. And so from there, it was really a process of go build Inovalon. So the creation of Inovalon's first headquarters outside of Baltimore ensued. Okay, just kidding, that's not our headquarters outside of Baltimore. That was our headquarters outside of Baltimore. So if you look at the early proverbial documentation of the company, it basically said the address of the spare bedroom next to the baby room on 26 Stable Run Court. And literally every expense was at 18 to 22% interest. We didn't have any money. The checks that I wrote to form the company, to buy the first business cards, to buy the first stationery, were done on Visa credit card checks, all just borrowed off of tomorrow to enable this concept of this dream of being able to make healthcare better. This was just the early years of technology, the early years of technology in healthcare. Homes were just getting used to hearing the whir and the buzz of a modem. AOL only had 12 million subscribers at this time, all of them dial-up. Dell was just starting to grow. It was an amazing time that the world was starting to wake up to the fact that this concept of the internet might actually make it. As a matter of fact, you could use it for more than just sending emails or saying hi to a friend at a distance. The number of households in the United States that used the internet on the year that I graduated from college in 1991, a year when every room I was in was wired to the internet, it was a way of life in college, was 1% across the United States. By 1998, the year of the origins of Inovalon, it had risen to 41%. A massive adoption was occurring regarding how the technologies of data transition and transfer were going to operate. And at the same time, state departments of health around the country were wrestling with this expansion of managed care. How were we to oversee them? How were they to be credentialed? How were they to be certified? What rules should we, a state department of Michigan or Arizona or Nevada, what should we require of them to make sure that they deserve their license and their credentialing year after year? Frankly, they struggled with it. They came up with these very strange, in retrospect, requirements. As a health plan, you would need to submit a list of every provider that was in your organization's network. And you'd have to say strange things like the hours of operations of the provider. And believe it or not, the number of chairs in the waiting room. The only reference to clinical information in the early applications for certification was whether or not the doctors, on evaluating a 5-chart sample, consistently used the concept of SOAP, subjective, objective, assessment, and plan, or the SOAP note standard of medical documentation. Not what the content was, not whether or not it was a good or bad diagnosis or decision. These were the early requirements. But what these were was a need for data aggregation and data reporting. And as fundamental and as rudimentary as it was a do work once and use multiple times, right? Because a health plan, there might be 10 or 15 in a state. They're all using very similar providers. So we derived a way to capture this information and accumulate it and map it to the right health plan and provide this service of value to this early burgeoning managed care marketplace. So we started to grow. And we actually moved out of the spare bedroom into this giant 2,200 square foot office. We had 6 employees at the time we bought our first server. It was an HP LH3000. I bought it used at a HP conference actually here in Washington, D.C. They didn't want to ship it back to wherever they would ship it back, so they sold it to me off of the floor. It was massive, it had wheels, it was loud. We put it in a closet. That was the first IT system of the company. I would sit there at night with Microsoft on the phone trying to load small business operating systems onto this server and trying to set up email systems in this whopping office of 5 to 7 people. We didn't have a photocopier. We would take things that needed to be photocopied, they'd go in the little bin on the front desk, and whoever left last that day, which was invariably me at 2 or 3 in the morning, would swing by Kinko's, which fortunately was 24 hours, make photocopies and bring them back in the morning. It was a tough start, but it was a pretty amazing time. We didn't know what was about to come next, which was really the collapse of the technology and financial markets of the dot-com era. Overnight, buildings that I used to go to try to form relationships with tech companies were vacant. I would literally drive to one where I'd had a meeting 2 weeks before, walk right in, not knowing that the doors had been left unlocked and everybody was gone from the building. It was an incredibly scary time. But fortunately, while the technology and financial worlds were collapsing, this woman was rising. This woman is Peggy O'Kane. Peggy O'Kane had started the National Committee for Quality Assurance in the early 1990s. And she was trying to develop this concept of measuring how an HMO was doing clinically so that employers considering to use that health plan might know good from bad. The original name to it was the HMO Employer Data Information Set, or HEDIS. It didn't change its name to the current version of health effectiveness until 2007. But anyway, Peggy had launched this thing called HEDIS 1.0 in the early 90s. It didn't go so well. It wasn't adopted. People didn't think it was very useful. She then came out with HEDIS 2.0 in the mid-90s. Still, it kind of got an eh. It wasn't until Dr. Carrie Sennett, who would eventually become the chief medical officer of Inovalon for a while, came out with HEDIS 3.0 in the late 90s. And suddenly it started to get traction. And how did traction look? The state departments of health in those different states who were trying to oversee managed care said, let's add this to the list of things that health plans need to do in order to get their certification. Importantly, I'll point out, it didn't matter what your score was. It was a checkbox. You had to do this. But it had to be done. And so the data collection necessary for the actual clinical quality of samplings of patients within health plans was born. And it took off overnight, and so did the growth of Inovalon with it. We moved to a more proper office. Ironically, 180 Admiral Cochrane was one of the headquarter buildings of one of the giant ASPs in the outside of Washington, D.C. area. So the halls that I had previously walked, hoping to get a meeting with somebody important so I could talk to them about my ideas of healthcare, now were completely vacant, and we moved in. At the same time, the early 2000s, we're starting to see all this dark fiber and everything that was laid at any expense in the late 90s get lit up. Internet connectivity was starting to soar. DSL coverage and cable coverage and bandwidth was starting to expand significantly. It was getting easier and easier to find doctors' offices and hospitals that were actually connected to the internet. This started a burgeoning expansion for the company. And then, overnight, tectonic shifts occurred. Because in 2003, the Healthcare Modernization or Medicare Modernization Act was passed, and suddenly the actual detail of each individual patient, not just a sampling for HEDIS, but in fact, every patient's diagnosis data suddenly became important. And while we had grown to be known, this company that could capture and aggregate and analyze and normalize and report data for the elements of quality in the early 2000s, now suddenly we were really in need to capture data as fast as we could from as vast of an area of the country as we could. We grew in multiples of 100% each year. And while this was evolving, this was also giving us the ability to look at data from not just one location, but all the locations that we needed to. Because at this point, only about 47% of doctors' offices were connected, which means that most were not. So this little-known person came along and said, you really should have an iPhone. And more important than the iPhone coming into existence, the concept of mobile connectivity took off. Suddenly, cell towers were springing up everywhere, and connectivity at even the most distant facilities became available. You know, we think about healthcare in the metropolitan areas, but the vast amounts of the United States cares for members that are in one or two doctors' offices, and they don't receive the same care that they do in larger metropolitan areas. So this expansion into mobile connectivity and data blossomed a new era. We launched technologies that would allow for remote collection of data from any corner of the country that our customer needed. We fanned out across the country and create armies of people that would learn our technology, learn our software, learn how to capture this information, and beam it back to the mothership for us to analyze it. It was a tremendous time of growth. But of course, fate would bring other things. In the 2007, 8, 9 period, the housing market collapsed. And the financial marketplace again went into disarray. But very fortunately for Inovalon, this economic transition brought significant benefit to the company. And significant benefit as we look back to the progression of technology in our healthcare marketplace. Because as unemployment was hitting 10%, states were struggling with fulfilling their Medicaid financial obligations. So they started to privatize the Medicaid marketplace and offload them from the balance sheets of the states onto the private market. Managed Medicaid listed only in the few million, multiples of millions prior to it, but by the end of 2010, there were more than 19 million patients in managed Medicaid. That was a really significant transition. By now, the internet had penetrated over 75% of homes. Doctors' offices and clinical facilities were actually coming online by the thousands every single day. And the demands of this data availability in the setting of the expansion of Medicaid started to become pretty prevalent, but it needed a kick. And that kick came from that same force of the financial downturn. It came with the passage of regulatory stimulus for the industry. And part of that stimulus was the HITECH Act. The HITECH Act put into place $35 billion to facilitate meaningful use and connectivity and EHR spread across the marketplace. So what was happening was the expansion of privatized healthcare was being facilitated by the economic downturn. Stimulus and incentivization of connectivity and use of meaningful use was being facilitated by the downturn. And at the same time, the economic challenge of the environment was weeding out and culling out companies just couldn't cut it. Inovalon was becoming more and more distinguished in the marketplace. We were resilient, we were delivering on what our customers needed, we were innovating, and we were bringing value to the marketplace at an incredible pace. And this marketplace was starting to appreciate the benefit of value over volume. And that brought in an incredibly important, another tectonic shift, was the adoption of the Affordable Care Act. The Affordable Care Act, which came in 2010, suddenly said, value matters. Matter of fact, it matters so much that your quality scores now translate into a financial incentive. So no longer is it just a disease status that was made relevant in 2003's Medicare Modernization Act. Now we're saying not only disease, but the outcome matters. Clinical quality scores started to become a focus of the industry. Patient-level data analysis was critical. And overnight, people needed to gather this information to survive and succeed. As we did this, we started to also see that the speed of compute started to matter. And our growth across the marketplace took us to our new corporate headquarters, where we started to focus on how can we make the software faster. You see, as you all know, HEDIS used to be something that needed to be calculated once a year. But if the outcome was so important, if knowing the outcome was so important, then being able to predict it became important. And if the ability to predict it and then improve it became possible, being able to do it repeatedly would increase your probability of actually getting to your critical outcome goal that you wanted to be on. So suddenly, being able to do it quickly and repeatedly and improve the patient's outcome became a focus. And these massive data sets needed to be able to be computed, aggregated, normalized, and implemented into our marketplace more quickly and more quickly and more quickly. These required significant investments, innovation, and new thinking of how to do this. This was new to the healthcare marketplace. So slowly, at first, and then very quickly in avalanche, what you were seeing was accelerated Darwinism. Organizations that used the Inovalon quality analytics platform were doing better than those who were not, repeatedly, reliably. And the way the STAR quality system works is if you are getting a better quality score, you get a financial incentive. And that financial incentive is actually paid indirectly by those organizations that don't get a good quality score. This was causing a massive shift towards those that could figure out how to achieve a better quality outcome. This was meaning that those using our software were growing faster than those not using our software. And very importantly, this was showing that policy, backed up by incentive, supported by empowering technology, could change the market. And in fact, Inovalon was realizing its mission of truly being instrumental to the improvement in outcomes and economics of healthcare. We were achieving our mission. And with our success of our customer came our success as a company. And we went public on the NASDAQ marketplace on February 12th, 2015, my son's 12th birthday. It was an amazing time. We used this capital to apply to massive internal and external investments. We knew that the market was converging. Health plans were starting to buy or build post-acute care facilities. Providers were starting to build pharmacies. The lines between these once completely separate silos were blurring. We needed a larger software platform that could speak to all of these constituents, that would help the most complex and sized organizations in the marketplace better operate, leverage the data of their members across the different applications, and more effectively achieve their goal. So in 2015, we made our first acquisition post going public and bought Avalere Health to add significant number of data scientists and life sciences knowledge base to the company. In 2016, we went on to buy Crehan Health to add pharmacy software platforms to the portfolio. And in 2018, we bought Ability Network to add provider systems and capabilities to the portfolio. But adding software to the portfolio is just one step. Bringing it all together into an increasingly sophisticated software platform is crucial. We focused on being able to advance the way that our software ran, the way that it spoke together, the way that we could scale the speed and efficiency of the system. And it wasn't easy. Indeed, the cloud capabilities, modern cloud capabilities, first came to market in 2006 by Amazon, 2008 by Google, 2010 by Microsoft. But it wasn't really until 2015 when container orchestration systems of Kubernetes 1.0, released by Google, really started to blossom cloud adoption. And unfortunately, the healthcare marketplace was really slow to embrace commercial cloud capabilities. There was an inherent concern of where is this data center that's going to be running my compute and holding my data? And so Inovalon had to embark upon a very expensive dual process. We had to start learning more and more about commercial cloud capabilities, but at the same time build very expensive private data centers for hybrid cloud environments. It was the right thing to do, but it was an enormous burden. And by the end of 5 years, we had spent more than $2 billion investing in expanding our software platform to meet the needs and demands of our customer base, integrate and develop and advance the sophistication of our software. But there was so much left to be done, so much left to be done. And unfortunately, a lot of that got interrupted by suddenly, just a month later, the World Health Organization declared a global pandemic was occurring. And suddenly, overnight, we had to worry about how do you manage 18,000 customers and take care of them and run a publicly trading company from your home. It was an incredible, incredible time. Well, we're very fortunate that, first of all, we had a pandemic plan, which was amazing that we had put in place a plan of what we would do in case something like this happened. Secondly, of course, our technology infrastructure was based in data centers which could be remotely managed and commercial cloud that could be remotely managed. So our operations were able to continue. Even our phone systems had recently been transitioned into cloud and data center available systems. So we could support our customer, we could develop software, we could manage the company and help out the marketplace despite being at home. Within a few weeks, it became apparent that COVID wasn't going to be a terrible event for the company. It was going to be a source of thriving to support the marketplace. And once large in-person meetings started to be done in a streaming fashion, software development was done in India and the US remotely from our employees' homes. We started to innovate new products like remote clinical encounter software and software that we'd make sure that providers could administrate their practices remotely. And things like vaccine adherence became innovations of the time. And the company stood out amongst its competition in the marketplace. We were there for our customers. Our innovation, our perseverance, our dedication shone through, and people were not missing a beat. So as the dust began to settle, we saw that we were thriving. And after 6.5 years of being public on the NASDAQ, the company made the decision to allow itself to be bought at an all-time high for $7.3 billion in 2021. What had gone from a spare bedroom in a townhome north of Baltimore was one of the largest technology transactions of the year. And the decision was made so that we could focus on innovation. We knew, we had just learned, we had just experienced that the things we needed to do is to stitch everything together and achieve the realization of truly innovative software architecture and design required a massive number of transformations. A number so significant and so costly that it couldn't be done as a publicly traded company. It could only be done by being private. So now, 2 years on from going private, we're back in the office again. We're having meetings face-to-face again. Implementations are being done in person again. Events like this are now becoming normal again. The company is thriving. They're thriving, though, because of the relationship with all of you. They're thriving because our innovation and ability to adapt to change, ability to adapt to the evolutions that are inherently present across the healthcare marketplace, across the regulatory marketplace, across the technology marketplace, are ones that need to be embraced by people with a dedication to innovation and a dedication to a mission. Our mission is to improve outcomes and economics of healthcare, and we do that with all of you. Over the next 2 days, you're going to meet some amazing people. You're going to hear some incredible minds talk about what they are doing and what we are doing. You're going to hopefully learn a ton about Inovalon, a ton about our people, and a ton about each other. This is a time of change. This is a time for innovation. And Inovalon is completely dedicated to not only that, but the success of all of you. Thank you very much for joining us for this journey. Thank you for joining us for Customer Congress 2023. We're grateful for all of you. Thank you.